Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Thank you. And we're going to be talking about renal mass imaging at its basic level and then where it may be going in the future. These are my disclosures. The problem we're facing is that renal cell carcinoma is common, but usually incidental, and the incidence keeps going up. There are risk factors, some of which are clinical, but one of the driving risk factors for the rising incidence of renal cell carcinoma is getting imaged. If we take more pictures, we tend to find more small renal masses. And these data show the challenge, where the incidence of renal cell carcinoma is going up significantly since 1975, but the mortality is not changing very much. Only in the last few years has it started to mildly decrease. And this kind of graph implicates overdiagnosis and overtreatment. So we're finding a lot of masses, but we're maybe not always delivering value when we find them. In most patients with a small renal mass, surveillance can be safe. So let's say we find an incidental renal mass, what do we do with it? Our low bar goal when characterizing a renal mass will be one, sort of exclude inflammatory, infectious, or vascular causes. And once we've done that, we put it into a category. Is it cystic or solid? And the definition of solid is it has at least 25% of its volume is enhancing, and cystic is less than 25%. If it's cystic, we want to assign a Bosniak class or say it's a simple cyst. We want to avoid qualitative terms like complicated cystic mass because that doesn't communicate as well what we're seeing. And if it's solid, we want to mention whether it does or does not have macroscopic fat. If it has macroscopic fat, in almost all cases, it's a benign angiomyolipoma with some rare exceptions. The definition of enhancement depends on whether you're looking at CT or MRI. I mentioned before that a solid mass requires at least 25% of the volume of the mass enhancing. So what does that mean, enhancement? At CT, if it's increasing in attenuation between phases of at least 20 Hounsfield units, that's enhancement. If it's 11 to 19 Hounsfield unit change, that's equivocal. And if it's less than 10 Hounsfield units, that is technically not enhancement, although I'll show you some caveats to that. At MRI, quantitatively, it's at least a 15% increase in signal intensity between phases. And it's very important that the signal characteristics, or the sequence characteristics rather, are identical across those measurements. If it's less than 15%, technically it's no enhancement. And subtractions can be used to qualitatively assess enhancement, but please do be careful because of motion artifacts. I mentioned that macroscopic fat can be very helpful to detect because it almost always indicates a benign mass. And at CT, the definition is a region of interest of at least 5 millimeters diameter, and you come back with a measurement of minus 10 Hounsfield units or less. At MRI, seeing something lose signal intensity on a fat-saturated sequence compared to a non-fat saturated sequence of the same type, that can indicate macroscopic fat. Indie-ink artifact around a glob of T1 hyperintensity can indicate macroscopic fat. And please be careful about the difference between macroscopic and microscopic fat at MRI. So microscopic fat, which is sheet-like loss of signal intensity, can also be seen in clear cell cancer, for example, whereas macroscopic fat tends to be only present in angiomyolipoma. When measuring attenuation, to look for enhancement, be careful at CT when there are small masses, endophytic masses, masses next to avidly enhancing parenchyma, because those can all be risk factors for pseudo-enhancement or false enhancement. Also, be careful because papillary cancers may not show enhancement at CT, and the key thing to look for there is heterogeneity. So let's say we find an incidental low attenuation mass at portal venous CT. How do we know whether we should go on and work it up or not? And this does speak a little bit about the effects of pseudo-enhancement. So this was a study performed in 2017, and it looked at the math around finding a mass that measured 21 to 39 Hounsfield units and homogeneous at portal venous phase CT. And if you think about it, if we need 20 Hounsfield units of increase to indicate definite enhancement, and a cyst is typically less than 20 Hounsfield units, something that's between 21 and 39 household units may, in fact, just most likely be a cyst. And in fact, that was sort of supported by these two studies here. In 2017, there were no solid masses in 42 that had a reference standard out of 1,387 scans. And in another study, they found 0 solid masses with attenuation 20 to 30 household units and 30 to 40 household units. And the key here is make sure it's homogeneous. If it's heterogeneous, all bets are off. To confirm that work, this was a multi-center study, 12 centers, 12,000 examinations, looking at masses that were 10 to 40 household units and homogeneous, keyword, 21 to 39 household units. There were 346 that had a reference standard, and none of them were clinically important. So the current guidelines from Bosniak version 2019 indicate that if the mass is homogeneous and less than 30 household units at portal venous phase CT, it can be ignored. So I talked before about if you see a cystic mass, we're going to put it in the Bosniak classification. This was updated in 2019, and the intent of the update was to incorporate MRI, establish definitions for previously vague imaging terms, and to try to push things into lower risk classes to decrease the likelihood of overdiagnosis and overtreatment. And a key piece of this is that the authors suggested that validation would be required. And we couldn't just say, well, this is the way that it is. It's a constant living work. I mentioned before the major goals were to improve specificity, improve inter-rater agreement, provide clear definitions for terms, incorporate MRI, include more masses that might be eligible, and standardize reporting recommendations. So a few pearls about using Bosniak version 2019 in your practice. Make sure it's a cystic mass. We talked about that definition being less than 25% enhancing. Inside this document, there are a variety of measurement guidelines. So for example, the word thick means 4 millimeters or more. That's a guidepost, not like a legal standard. When trying to assess a mass, use multiplanar imaging. So when trying to determine how thick something is or whether there's a nodule, use your sagittal, your coronal, and double oblique measurement or reformats to evaluate that. And features must enhance in order to count. So be careful if you're looking at something on T2-weighted imaging and it just looks like there's some junk in there. If it's not enhancing, it doesn't really count as a septation. And really the system is simpler than it first appears. Now I'm going to show you a simplified version of how to think about the 3 major classes, which are 2F, 3, and 4. So version 2019 says a Bosniak 2F mass is something that's got smooth, minimally thickened enhancing wall, or smooth, minimal thickening of 1 or more enhancing septa, or many smooth, thin enhancing septa. So the key terms here are minimally thickened, which is 3 millimeter, or many, which is 4 or more septations. So think about minimally thickened or many, and that's 2F. 3 is 1 or more enhancing thick or irregular walls or septa. There's the definitions there. So if 2F is minimally thickened or many, 3 is thick or irregular. And 4 has a nodule, 1 or more nodules, and there's the definition of what a nodule is. It's anything with an acute angled margin or an obtusely marginated thing that's at least 4 millimeters tall. One thing to be careful about is our masses that are heterogeneously hyperintense on T1 weighted imaging. This is the one example of something that can be pushed into a 2F that does not enhance. And the reason why is because this indicates there's a lot of blood in the mass, and papillary cancers can look like that. Enhancement in Bosniak version 2019 is binary, and it's the morphology of those enhancing features that drives the class assignment. It's no longer does it enhance or not, it's what is the morphology of those enhancing features. So this is sort of a graphic that shows how to measure whether something's an irregular thickening or whether it's a nodule. We're going to measure perpendicular to the wall or septum like that. And we're not going to measure that underneath portion right there. This is irregular thickening. So it's 3 millimeters, 2 millimeters, 1 millimeters with obtuse margins. And these are nodules, 4 millimeters or more thick, and anything with an acutely angulated margin. If it has a nodule, it's Bosniak 4. If it's irregularly thick, it's Bosniak 3. I mentioned before how important it is to look at homogeneity. So here's a mass where we're making a region of interest right in the center of the mass, and we're not seeing much difference there between the pre and post contrast imaging. But when we narrow our windows down and look, you can see there's sort of multiple tones inside the mass. And if we were to make some measurements inside there, you can see that this mass has a 52 household unit component and a 65 household unit component. And because of that heterogeneity in the size, it was pushed over to MRI. And you can see this is the same mass here. Looks like it's got a lot of blood in the center, some solid enhancement along the wall. This is a pretty nasty mass, and this is not something we'd want to ignore. So be careful. If you see something heterogeneous at CT, don't rely on non-enhancement. Push that over to MRI. So there are 3 reasons to get an MRI after a renal mass protocol CT. If it's 3 centimeters or more and hyperdense, or it's heterogeneous, or there's so much calcification you can't evaluate whether the findings are enhancing or not. And the example I just showed is an example of a heterogeneous mass. There are some challenges or weaknesses of Bosniak version 2019. Role of ultrasound is not fully established. That's being worked on right now. It primarily relies on anatomic features, and the predictive value of individual features is unknown. So a specific features prediction is unknown. Cystic change and necrosis are hard to distinguish. In general, necrosis is going to have a thick outer wall, and the necrosis will be centered. Mass size is not included in the classification. And this is the key weakness, is that Bosniak version 2019 predicts likelihood of cancer, not biologic behavior. And this results in a lot of indolent masses being resected unnecessarily. If you look at the literature, about 30% of Bosniak 4 masses are aggressive cancers, and about 10% of Bosniak 3 masses are aggressive cancers, and which means the majority are not aggressive. So if we're trying to move away from overdiagnosis and overtreatment, we have to reframe our thinking away from predicting cancer of any type to predicting aggressive cancer. And there have been a few groups that have worked on this to try to solve this problem. One of the most notable or influential was designed by Ivan Pedrosa and his team, the clear cell likelihood score. And I'm not going to go through this algorithm in detail, but the key point is that imaging features, which are located on the left-hand side of the screen, are used in combination in serial order to try and predict how aggressive something is, with the focus being on trying to predict clear cell cancer. And the scores there are on the bottom. The intent of looking for clear cell cancer is that of patients who have metastatic renal cell carcinoma, clear cell cancer tends to be the cause of that metastasis. So we're using clear cell cancer here as a surrogate for aggressive disease. And this was evaluated in a multi-center study trying to predict or trying to assess how accurate this system was. And this study had 250 masses over 5 centers. And you can see that a CCLS score of 5 had a positive predictive value for clear cell cancer of 81%. CCLS scores of 4 and 5 had a sensitivity of 75%, and a CCLS score of 1 to 2 had a negative predictive value for clear cell cancer of 88%. And the reason why these weren't, astounding or amazing accuracy data is because each site had their own protocol, their own readers, their own templates. And if this is going to become, for prime time, this would need to get tuned up. So some of the challenges of using a system like this are, the accuracy remains suboptimal across sites. Cystic and solid are still treated separate. So the CCLS system is focused on solid masses, and cystic is still using the old paradigm of Bosniak, which is focused on predicting any cancer, not aggressive cancer. And CCLS scores are focused on predicting clear cell renal cell carcinoma, not aggressive cancer of any type. So for those reasons, there is a group, including Ivan actually, who's going to be the chair of this committee, that's working on a KI-RADS, or a kidney imaging reporting and data system, through the American College of Radiology. And right now it is a works in progress. What I'm showing on the screen here is not an actual guideline in practice, but it is a hypothetical framework where mass is assessed for likelihood of cancer, and then we determine what the aggressiveness is, and then we assign the KI-RADS score so that we're getting away from just predicting likelihood of cancer. For example, a mass that has a pretty high likelihood of cancer, like a Bosniak 3, which in modern days is about a 70% chance of being a cancer, but also tends to be indolent. About 90% of Bosniak 3s are indolent, so this would be assigned a score of KI-RADS 2. As a hypothetical example, again, this is just for demonstration purposes. So in summary, we covered how overdiagnosis and overtreatment have really plagued the diagnosis of the management of the incidental small renal mass, and we've got to figure out ways to address that problem. We covered definitions for enhancement and macroscopic fat, and highlighted how macroscopic fat is often associated with a benign mass, an angiomyolipoma, but microscopic fat is not helpful for discriminating benign and malignant masses. We distinguish solid from cystic masses. Again, solid is 25% or more enhancement, and cystic is less than 25%. We talked a little bit about different advantages of CT versus MRI, and in the future, predicting aggressive cancer is where this field is going to go because of the need to reduce overdiagnosis and overtreatment. So thank you very much, and I hope this has been educational.